Hello friends, why talk about ergonomics? Many surgeons fail Etep not because of anatomy, dissection skills, mesh placement, but because of wrong port placement, poor body posture, instrument conflict, and loss of triangulation, and also uncomfortable operating angles. So, bad ergonomics creates difficult surgery. I am Dr. Rahul Mahadar. I am going to talk about Etep Inguinals, ergonomics of Etep Inguinals, how to make it easy. So, as you know, for any open surgeries, we always think about the position of the surgeon, position of the patient, and how you are standing. So, same way, the working posture of the surgeon matters in laparoscopic surgery. So every ergonomic problem in Etep begins when this triangle is broken. So if you see here, the target and the monitor and the surgeon in one line. So, and the monitor is below the eye level at least by 10 to 15 degrees, and this is the comfortable position with which one should go ahead and do Etep inguinals. So most importantly, the position of the patient. So position of the patient, either hand tuck or right hand of the patient is kept aside, and surgeon is standing, as surgeon is a right hand surgeon, he will be standing on the left side of the patient. The assistant or the camera person is standing besides him towards the head end of the patient, and once completed the opposite side, that is on the right side inguinal hernia, for the left side hernia the position exactly changes as a mirror image of this to the opposite side, and then you can carry out the procedure, the monitor being at the leg end of the patient in the middle. So this is the operation table setup. Either the operating surgeon is a right-handed surgeon and the camera person is a left-handed, then he can stand opposite side of the patient's shoulder, so that he can carry out the operating maneuvers easily, the camera maneuvers easily. So this is the position you can see while deployment of the mesh. It is showing that the patient, the surgeon is at the comfortable position, hand movements are at the elbow level, and the wrist is very comfortable position. Here you can see this is while dissecting. Also you can see the camera person is standing at the opposite side, and this is even for the lateral dissections, the surgeon's position and the angle of the elbows and the wrist should be at a comfortable level, so that the dissection is very precise. But if you compare this with the standard midline ports, then you can see the crowding of the instruments and the struggling of the surgeon, then the shoulder movement, shoulder of the surgeon which is raised, the hands are raised. So this is not the ideal position. So the instrument angle rule is most important thing. The ideal angle between the instrument should be 45 to 60 degrees, and not a 10-degree parallel instruments like this, and also not a 90-degree excessive spread like this. This also creates a strain on the shoulders of the surgeon, so that it will become a difficult. So the most important thing is the correct angle. It reduces the effort by 50%. So the angle of the instruments is towards the, if you calculate it towards the organ, then manipulation angle should be between 45 to 60 degrees, and azimuth angle is around 30 degree between the optics and the one hand instrument. So this has been maintained with this Etep port position, wherein you can see here the angle, azimuth angle is also maintained, and the manipulation angle is also between 45 to 60 degrees. And for the opposite side, either you can use these two port positions, or you can shift the optics in the midline port, mid port, and then you can utilize it with the lateral hand instrument as well. So the most important aspect is the monitor position, which is a forgotten factor, and many surgeons ignore this, and because of this there is the shoulder pain, the neck pain that starts. So the most important thing is monitor should be directly facing to the surgeon. It should be at the eye level, and 10 to 15 degree downward gaze should be there, so that there will be no neck sprain after the operation. And the distance between the monitor and the surgeon's eye should be minimum is 1.5 to 2 meters, and never the monitor should be on this one side, or it should be too high, or even the monitor is behind the assistants, that is behind the scrub nurse, so that you have to bend your neck and see what is going on the monitor. So coming to the surgeon's position, the surgeon's position is most important thing. His neck should be neutral, the shoulder should be relaxed, and elbows should be at 90 to 120 degrees. The wrist should be neutral, and the foot shoulder width should be shoulder width apart. So the distance between two legs should be a shoulder apart, so that this is the surgeon's position, wherein the surgeon makes it very comfortable movements. And so the rule is, if your shoulders are elevated, your ports are wrong. So assistant ergonomics is also important. Good assistant makes Etep easy, poor assistant makes it miserable. So the assistant, that is a camera person, should be either just at the shoulder of the patient on the left side, just behind the surgeon, or otherwise he should be standing on the opposite side, and he should make the movements if he is a left hand person. The position of the camera movement position is this, and the camera movement should be minimal. It should be stable horizon, that is the movement should be in a one horizon only, sidewise, and very precise movements. And there should be anticipatory movements according to the surgeon's needs. That means when the surgeon is moving the instruments, the camera person angle should be maneuvered properly by the camera person. So the most important aspect is port positions then. So standard port positions, what we know for the standard Etep Inguinal Hernia Repair is both the working ports in the midline, and camera is just below the umbilicus. But in case of a Etep, what Jorge Dias has suggested is the shift the camera port to the lateral or the anterior, towards the anterior abdominal wall, and from where you can extend the view, or you can enhance the view, and with these two hand instruments then you can tackle either side hernias according to the need. So the most important point here is there is a high camera port placement, which is way above and lateral to the anterior abdominal wall on either side, so that you can tackle these. So what is the difference between the TEP and Etep? So TEP is a limited space is there, so fixed port positions, what we do in case of a TEP. Instrument fencing is there, and restricted movements are there, and you have to manage according to that. And it is difficult in case of obesity, it becomes quite difficult with the TEP procedures. But in case of a Etep, if you compare, there is a large space is there, then the flexible port positions, the instrument fencing is reduced, and restricted movements which are not there in case of a Etep. There are wide movements which we can see or which can feel, and it is easier in case of obese patients. So Etep provides freedom, but only if the ports are positioned intelligently. So for this, one should know the width of the rectus. It is ranging from 4.5 to 12 centimeters with an average of 6 to 8 centimeters. And how you can measure this, you can see the lateral border of the rectus is, if you have a ultrasonography in your OR, then you can mark the lateral border of the rectus muscle with the help of ultrasonography before the operation, or otherwise we have come up with a surface marking and the port positions for the enhanced view, that is a Etep repair for inguinal hernias, myself and Dr. A.M. Arora. And this is where in this paper what we have suggested is the surface marking is midline represent a linea alba 7 centimeters on either side. If you draw a vertical line, this will represent the lateral border of the rectus, and 4 centimeter below the umbilicus, if you draw a horizontal line, this will represent the arcuate line. And with this you can now place the ports. So my philosophy for Etep port placement is place the ports for the comfort and not for the anatomy, because anatomy remains constant, patient size changes, and BMI also changes, and hernia size also changes. So even though all these things happen, still the port placement should adopt all these things, and it makes the procedure comfortable and makes surgeon comfortable. So the port position is like this: the 12 mm port way above and lateral to the anteabdominal wall, 5 mm port just at the inferior border of the umbilicus, and 2 lateral ports lateral to the inferior epigastrics as shown in this particular figure. And here, if you want, you can change this 5 mm port from one side to above or below. Here also you can go above or below. Here this 12 mm port also you can change little above or little down as well if the need be. So this is the lateral border of the rectus, and then 4 centimeter below the umbilicus is a horizontal line, and now 5 centimeter lateral to the umbilicus and 3 centimeter above. Here is the first optical entry or first entry for the optics that can be done, and this is what is called as a Horje-Dias point up till now. And for the right side inguinal hernia, you can do a optical entry or a open entry like this, then put a lateral port at the junction of this lateral border of the rectus line and the arcuate line, above or below according to the need. Now in this patient is little on a obese side, so it is put on a upper side on the left side, and then you can put another trocar just at the inferior border of the umbilicus. This will maintain the ergonomics. Surgeon is standing on the left side for the right side of inguinal hernia, and then with these two instruments you can dissect. Now here I am using a scissor on right hand side and bipolar on the bipolar grasper on left hand side. The choice of the instruments, like many of the surgeons nowadays, they are using the bipolar cutter on one instrument and other is a bowel grasper, and you can conduct the procedure. Or some person they prefer to go for ligature or harmonic. That is the surgeon's choice. This is my choice for this particular operation. With these two instruments, majority of the work, more than 95% of the work is done by only these two instruments for doing a inguinal hernia surgery. So for the left inguinal hernia surgery, now surgeon is standing on the right side of the patient. Again 5 centimeter lateral and 3 centimeter above will be the optical entry, and then put a lateral trocar, and then the trocar at the inferior border of the umbilicus, and then with these two instruments one can carry out this left inguinal hernia repair. And for the bilateral inguinal hernia repair, what you can see here, after taking a 5 centimeter lateral and 3 centimeter above the umbilicus on the left side, once you enter with the optical trocar, then what we can do is you can put a trocar on the left side So the first working trocar comes here, and with this we can do the division of the posterior rectus sheath if it is needed in that patient, because as this patient, the distance between the umbilicus to symphysis pubis is around 11 centimeters. So we have done the division of the posterior rectus sheath, and after that one can put trocar at the inferior border of the umbilicus, and with this we can carry out the right inguinal hernia dissection. And after that I am putting a third trocar again at the junction between the lateral border of the rectus and the arcuate line or the horizontal line which represent the arcuate line. At this junction I am putting the lateral trocar, and then the surgeon changes his position. The optics remains at the same, so optical person is remains in the same position, and surgeon goes to opposite side, and with these two instruments then the procedure is carried out for the left side inguinal hernia. The common mistakes which are seen worldwide while doing the Etep procedure is, the mistake is, number one is ports too close together as shown in this particular picture. So ports are very closer, working ports are crossing each other, camera is fighting with the instruments, and monitor is off axis, and see the shoulder position of the patient, and surgeon as having a twisted body. So result what happens because of this is, so because of this there will be fatigue to the surgeon, neck pain, back pain, and longer operative time. So to avoid this, one should always be comfortable for doing with the Etep procedure. Now we can see the ergonomics in case of an obese patient, where most surgeons struggle here. This is because of the abdominal wall having a fat which is hanging almost. So what happens is, while putting the ports, we draw the skin above and then put the ports, and because of that what happens is, here you can see the crowding of the ports that can happen, and because of this it becomes very difficult for surgeon to do or carry out the procedure. So for that, the tips being, place the camera on a higher side, increase the port spacing according to the need of the patient size, and use the longer instruments, and monitor is slightly elevated because of the size of the patient, and stand further back, so little back, so that you become relaxed, and with this you can now carry out the procedure. The benefit being, it is a less classing of the instruments and better pelvic reach that is possible with these particular changes what you can do. Now ergonomics for the large scrotal hernias, the special challenges being the deep target is there, so long dissection is needed. So you can use here the bariatric length instruments if it is needed, and there are stiff angles in case of a large scrotal hernias. So to carry out dissection from all the sides, that is most important, and for that you have to use long instruments most of the times. The solution being the higher camera port position, then comes is a wider working ports, that ports should be placed little on the wider side, and then more lateral hand position should be maintained, and then the frequent posture reset for the surgeon, because surgeon need to take a little bit of a lap in between, so that he can again reset his posture and then again carry out the procedure further, to avoid any injury while doing the large inguinal scrotal hernias. So there are other tough situations also, wherein you can see here previous operated sites on for the open appendectomy, then suprapubic scar is also there. So in such situations, if the hernia is there, then in that case what you can do is, you can go to the opposite side of the scar and then put these lateral instruments as shown previously. Same, you can use the hand ports like this, and then you can target this right side hernia, and if at all required you can put a additional trocar if it is needed for the assistant. So there is a flexible port position what we can utilize in case of a Etep. So here you can put another trocar. In case of a bilateral hernia, in such situations you can put another trocar on the opposite side after the dissection, after the carry out of a dissection on the opposite side a little bit, and then you can put this trocar and then you can carry out the procedure. Also there, if you want, you can put another trocar if at all it is needed for the assistant to avoid any injury or for the precise dissection. So another tough situation is like this. Here also what you can do is you can go to the opposite side, and from opposite side you can come and do the procedure completely. Or in such situation, if there is only unilateral hernia that is on the left side, then you can put a port on the same side of the hernia, but the trocar positions will be on the opposite side like this, and surgeon is standing on the right side, and then you can carry out the procedure completely. So there are tough situations like midline scar and this thing. Here also you can carry out with these the same principle, you can carry out the procedure. So there are special situations, midline hernia with bilateral or unilateral inguinal hernias. So this is depend on the size of the midline hernia. If the hernia size is more and is having a divarication of a recti, in that case then you can again do a surface marking like this, and then you can start doing the Etep from above down. So wherein you can put just below the costal margin, 4 fingers from between the two ports, the distance is maintained, and along the lateral border of the rectus you can put a trocas, and then midline crossover is done. And with this trocas you can carry out in the midline, and then you can shift this for the inguinal hernia. You can shift the trocar here, and with these two instruments you can carry out additional 2 instruments, you can carry out the procedure and put the meshes like this. But this if the hernia size, the umbilical hernia size is small, in that case, and if you are thinking of doing a pre-peritoneal repair for the umbilical hernia along with the bilateral inguinal hernia, in that case, or even you are doing the Etep procedure also, so for that you can do the same way as shown the port position. So you can do first the bilateral inguinal hernia repair with these 2 instruments. You can do a take an incision over the posterior rectus sheath and then put another trocar with these 2 instruments. Then you can carry out the right side inguinal hernia repair, and after that you can put another trocar. The surgeon is shifted to opposite side, and then you can carry out the left side inguinal hernia, and now you can put a suprapubic trocar here. Now optics is shifted here in this trocar, and with these 2 instruments then you can carry out the procedure bottoms up. Either you can do a Etep or you can do a PTEP or pre-peritoneal repair also, that is possible, and put a mesh in this particular situation. So my personal modification for the Etep inguinal hernia repair is a slightly higher camera port position, wider spacing of the instruments in case of obesity, and monitor closer in elderly surgeons. That is what I suggest, and early port adjustments if uncomfortable in the beginning itself. So first 5 minutes according to me determines the next 50 minutes. So tap 10 ergonomic pulse for Etep inguinal hernia repair. Create a space before creating speed. Camera controls the surgery, and your camera person also should be comfortable in position. Wider angle that wins. So don't chase anatomy. Adjust ports to the BMI. Monitor should be straight ahead. Avoid cross instruments. Relax the shoulders. Reposition early, and comfort improves the precision. So how to overcome? Laparoscopic inguinal hernia surgery has got a steep learning curve. Complications are common in early phase of a learning curve. So the proper knowledge of anatomy and a proper simulation training and need to get peered by senior surgeon is most important thing. The ergonomics of Etep formula, is a success is equal to space plus triangulation plus alignment plus comfort. When all these four are optimized, then shorter operative time, less fatigue, better dissection, and with this what we can say is Etep is not difficult, poor ergonomics is difficult. So when surgeon becomes comfortable, the operation becomes elegant. Thank you very much. These are my credentials.